education, and the D, as you know, stands for discussion, discovery, debate, discourse. And today's June 19th, and right next to me, you'll see a co-moderator of mine, Professor Emre Ilmaz from Germany. You want to say hi to everybody?
Good morning, everyone.
So Emre Ilmaz is a professor of trauma surgery and orthopedic surgery in the Berufsgenossenschaft Hospital in Bochum, Germany. It's a university hospital. It's the oldest and one of the largest trauma hospitals in the world. And more about that later. But he's a former research fellow here, and he's become, I think, second in command in that very famous trauma unit. And we thought on our customary mid-June dates that we would celebrate research from our fellows. Today, in our 1.5 hours and 90-minute session, we have a couple of 3 highlight projects that we're going to talk about through past fellows and present fellows. So you're going to get a wide potpourri of case discussions and research discussions. And we have an international audience with us, so we're celebrating our close relationship to our German colleagues today. And it's a collaboration across boundaries between neurosurgery, orthopedic surgery, and trauma surgery. So with us, we have Professor, he's right there in the middle in that screenshot, if you see him, Professor Basem Ishak from the University of Heidelberg. He's a neurosurgical colleague. We have Dr. Alexander von Glinsky, and he's at the St. Joseph's Hospital in Essen. And we have Dr. Jonathan Plumer, who's right now still scrubbed into his OR as well. And these are international guests. And so it's really cool that we have a wide variety of faculty from around the world, and specifically from Germany, who are here with us today. And we have 3 larger sections. So this 90-minute session will be subdivided into 3 categories. These are all trauma things that we've talked about, all topics we've talked about before. One is lumbopelvic fixation and lumbosacral trauma, and that's the first session. The second one will feature distal junctional failure, and 2 of our fellows, Dr. Cliff Pierre and Dr. Azea Daher, will talk about their research, and then we are talking about spinal infections. So those are the 3 main topics. Lumbopelvic trauma, and we have our fellow Dr. Dave Davis coming up. Do you want to talk a little bit about lumbopelvic trauma and what got you interested in that, Emre?
Yeah, good morning, everyone. Lumbopelvic trauma was always, for me, like a field of interest right away when I started in Bochum, because we are so fortunate to deal with a lot of lumbopelvic trauma, a lot of pelvic and acetabular fractures. And it always caught me that this area of the spine is like something like an intersected area between spine and pelvic surgery. I'm going to talk about more about later. And there are a lot of biomechanical differences with respect to other regions of the spine. And that was always pretty interesting for me.
So our first speaker is Dr. David Davis III. He's in the final month of his fellowship, and he's done his fair bit of lumbopelvic fixations. And to get us started, we thought we'd integrate all 3 aspects, lumbopelvic trauma and fixation, potential infection, and distal junctional failure in one case. And he was instrumentally involved in that, literally and figuratively. Good morning, Dan.
Good morning. Dave. Good morning. Thanks so much. All right. So an abbreviated jump forward in time for this gentleman. Extremely active 80-year-old male who had a history of a thoracic trauma, and through multiple surgeries resulted in a C2 to T2 posterior spinal instrument fusion. And he's now complaining of pain progressing in his right hip with associated loosening of screws and hardware, and he is neurologically intact. We attempted management with electromagnetic stimulation and bracing to no effect. And so eventually we made the decision to remove the hardware, take cultures, place PMMA spacers, and stratigraph, and the cultures returned negative. Of note, he had multiple treatments for osteoporosis and had undergone multiple pseudoarthroses, which required revisions, which are not pertinent to the point of this talk here. So then I've included some CT scans. So first I've showing the axial, and you can turn your attention to the left sacroiliac joint where you can see loosening of the screws and a large void and non-union of the sacroiliac joint. And then as we come through onto our as we come through to our coronals, you can better appreciate the gap in the lucency there associated with the hardware. So as I previously stated, we had tried all forms of conservative management. We decided to take them to the operative theater, and we took cultures and placed PMMA spacer beads, and the cultures returned negative. So we took him back. Oh, this was a lateral view, which is not important. So I want to make sure I don't show an incorrect patient. So we took him back to the operative theater and were elected for revision SI fixation through a percutaneous lateral approach. There we go. And you can see now that we placed 2 sacroiliac screws from the left position, that you see the fibular strut allograft from our removal of hardware, in good position. On his coronals, similarly, you can appreciate the fixation construct as well as the structural graft that was placed in the joint. And then finally, in our final standing films, it may be difficult to appreciate on the slide, but you no longer see lucency. Obviously, around our sacroiliac fixation, you see where the previous screw tracks were, and he has no pain at 4 months follow-up.
What was the time placement from the original sacroiliac hardware to the time of when you noticed the non-union?
It was about, before we noticed the non-union?
Yeah.
I think it was about 2 years.
2 years, okay.
Yeah, 2 years. And then so the time spacing from removal and cultures was about 4 months to the placement of the sacroiliac fixation.
And you said cultures were negative?
Cultures were negative, yeah.
And so what are your thoughts for what could have, alluded to this kind of development?
Yeah, this gentleman, suspecting infection was certainly correct, and taking a cautious approach was certainly important for this guy and is appropriate. This guy has undergone multiple treatments for osteoporosis and has had multiple pseudoarthroses, and so this was clearly, in hindsight, an aseptic process. But you don't really know if something's an aseptic process until you go in and do the cultures. So.
Gotcha. And I know that Dr. Chapman always kind of alludes to this progression of pseudoarthroses in these type of patients, knowing the spine is sort of treated as an organ system itself. Any concerns for progressive, neuropathic type conditions like Charcot or?
Yeah, it certainly has on the, I can go back to the preoperative pelvic CT. It certainly has a picture that looks like a Charcot pseudoarthrosis here in the, particularly in the axial cuts here. On his exam, he had a good sensory motor exam, but there's certainly a component. There's certainly possibly a component of that.
So Professor Ilmas, I know that you've done some of the most significant, more recent studies, both biomechanically and anatomically, and Dr. Ishak will discuss that in a short while further. In lumbopelvic fixation, what did I do wrong here? I mean, he had a standard lumbopelvic fixation. He healed his one side perfectly, and the other side did not heal. We had reasonable fixation. The revision surgery was done with doubled screws, doubled rods, and it failed. And why? Too much load? The neuropathic question is obviously a good one.
Yeah, absolutely. That's something you have to address. When I look at your pictures, it's always like I'm a little bit in an awe. So basically the sky is the limit when it comes to how much hardware you can put in a human being. So it's obviously a great fixation. But when you look at the saddles, it looks like he's a little bit like a Eng spine, like he's almost fused in a lot of areas except the pseudoarthrosis area. So this might be that you have a lot of leverage in there. So basically a lot of micro movements. But when you take specimens and they are negative, and he doesn't have any kind of rheumatological disorder, I think that was the right approach. And the other hand, he seems to be like a large guy. He's not? Okay. Was he very active? a very active person. So in compliance, like how would you, like what's your postoperative course for those kind of patients?
For this, I mean, generally you wouldn't restrict somebody with sacroiliac fixation. We got two really good bolts. So for him, we had no restrictions.
So they can do like, go ahead and like do full weight bearing right ahead? Okay.
He was on medication. I don't know whether you have a medication slide that I had worries about. Do you know what that was?
We didn't say it, but he was on multiple anti-osteoporosis treatments.
And he was on anti-resorptive drugs for quite a while. He had osteoporosis, he had a spontaneous hip fracture. I do think that that may have played a role in it, but again, this is one focal area. Biomechanics is the other. So SI screws so far, knock on wood, has been successful, but what's stronger, screws or iliac bolt fixation? What's better? Maybe should we switch to Dr. Ishak for that? Baz, do you want to take over for a second? So you saw this case, right? And feel free to critique what I did. And thank Dr. Davis for this intro. Mechanically, here, SI screws seem to have done the trick. Again, he's half year out. He's very happy. Feel free to critique me on my initial fixation, on my salvage fixation, but I always thought iliac bolts and lumbopelvic fixation is stronger than SI screws. So far, this is not the case here. So give us your thoughts, maybe a little literature review of what you've compiled.
Yeah, thanks, Dr. Chapman, for this great case, actually. And thanks, Dr. David. Yeah, actually, I don't have concerns in terms of biomechanics. I mean, a double pelvic fixation, this construct is very nice and very stable from a biomechanical point of view. And we know this. Dr. Fontunski did a nice study in Pennsylvania, testing like the biomechanical stability. And what I was thinking, I'm not sure if this is an osteoporosis thing, but what we have seen, I mean, in the pelvis it's very rare, but in the lumbar spine, that low-grade infection plays a crucial role, especially in pelvic loosening. And this is what we've seen. And then there were studies actually done to that, and they found some germs even in the pelvis. And then this is like my theory. I don't think it's like a biomechanical thing. I don't think it's not strong enough. I personally think there has been somehow a low-grade infection associated with.
Good. Do you want to talk about some papers there first, or do you want to go with Dr. Ilmez? Emre, do you want to take on lumbopelvic fixation?
Absolutely.
And then we'll have Baz discuss that. Is that okay?
Yes,
Right.
absolutely.
Professor Ilmez is going to talk about lumbopelvic fixation. He's a professor in trauma surgery and orthopedic surgery, and he has done his professorial thesis. In Germany, you have to write a professorial thesis on lumbopelvic fixation, so he's a world expert.
Wow.
All right. Good morning again, everyone. As already mentioned, I'm from the University Hospital of Bergmannsthal, Bochum in Germany, in the midst of Germany, in the northwest. We are a former coal mine area, and therefore our hospital was the first specialized trauma center in the world. And so we have a lot of trauma. And as already mentioned, we are talking about lumbopelvic trauma today. And when I think about lumbopelvic trauma, I think there are like at least 5 major problems which we should be aware of. The first one is the world is aging. And as the United Nations reported, we are talking about like 1 out of 6 people being 65 and older in 2050. To put that into numbers, it's like currently we are talking about almost 800 million people on the world, on the planet being 65 and older, and in 2050 it's going to be 1.6 billion. To put that into perspective, that is like almost the whole continent of China or India. So those are like crazy numbers. And according to the UN, this is an irreversible global trend. So we have to deal with those patients. And as we know from our friend Ronald Bletcher, who was here, former SNI fellow, those trends are not only true for the world, but for the US as well. So back in the day, we did a Charles database study with patients from Washington State, and he was able to show that the numbers of spine fractures in general are increasing. The average age is increasing, and especially the numbers of lumopelvic fractures are rising in the elderly patients. The problem that comes with elderly patients are, as known from the literature, we have a higher mortality, higher morbidity, higher complication rates, and higher readmission rates, and in general, a worse outcome. And when it comes to problem number 3, so how much experience do we have in treating those patients? I did a quick PubMed search with just some search terms in 2022, geriatric spinal pelvic fixation. I got 2 hits, and I did the same 2 days ago, and I got now 6 hits. So the number of literature of studies out there are increasing, but very slowly and steady. So I think you get the problem. The other thing is there are a lot of options theoretically how to fix bilateral sacral fracture, as you see on the top. But in my opinion, all those options placed at the bottom, like sacral plating, STI screws, and iliosacral bars, are not really an option. In my opinion, you can either go with an iliosacral screw or treat the patient with lumopelvic fixation. Problem number 5 is, as I already mentioned, like the lumopelvic junction is a little bit like the intersected area between pelvic and spine surgery, and sometimes feels like you're cutting the tree out of its roots. But in order to get grow in a meaningful situation, you have to put both together. So now I'm going to start with my case presentation. So I've looked up 6 cases, each one with a different fracture pattern, and I'm looking forward to your discussion and debates. Case number 1, 59-year-old male patient, polytraumatized, fall from the 2nd floor during a residential fire, pelvic C fracture, dislocated open fracture on both lower limbs, soft tissue defect on the heel and medial ankle, inhalation trauma, 2nd-degree burns on both hands and the right forearm, as well as a subscapular liver hematoma. So this is the CT scan. So as you can see, we have like a bilateral lateral fracture and a longitudinal sacral fracture, in addition to like a crescent-like fracture on the right side. So my question for the audience is, what are the treatment options in those patients, and how would you time the surgery?
What was the mechanism of injury again, Emma?
He fell from the 2nd floor.
Oh, wow.
So basically, he jumped out of the window because the building was on fire.
I mean, I think it needs surgery.
He does. I agree.
So,
Pretty easy.
so the old Harvard thing, and Dr. Chip Rout was instrumental in discovering that, was to sheet them. I don't know whether you still do that. We put a simple wrap around the patients and tighten them up. The question at the time was, do we do radiology? Do we do IR? Do we do vascular angiography if the patient's unstable? But sheeting the patient would be my first resuscitation measure, sorting out any bleeding, any internal organ failures that are pending, and then coming up with a probably anterior external fixator. And I think percutaneous SI screw fixation, popularized by Dr. Keith Mayo and then Chip Rout and Harvard, would be the way to go.
Yeah, I agree. Like in Germany, we have like a algorithm that those patients, like back in the day, like 15 years ago, those patients, they get a stiff neck and a collar, and but nowadays they get a collar and a pelvic binder. So in case you're in doubt if someone like him has a pelvic trauma or not, they will get a pelvic binder, and therefore we don't need the sheets anymore, because most patients show up in the OR with a pelvic binder already, at least until the CT scan. And we figure then out if we can release the pelvic binder or not. Controlled bleeding is very important to get an angio if you have like the rare anterior arterial bleedings in those kind of patients, like with severe pelvic trauma, C fractures. Like most of the hematoma comes from the fracture side, like about 60%, 30% from venous bleeding, and you can't control that with an angio, and only 10% from arterial bleeding. But you have to capture those, because those are always, when those patients are unstable, those are non-responders. Yeah. And you already mentioned the external fixator. That is actually what we did. So we put on an external fixator, put him on the ICU, and then we went on to do surgery like 3 days later. And we started with an anterior plating and then turned the patient and did a bilateral lumbopelvic fixation in addition to like a small plate to address the crescent fracture type.
Wow, that is beautiful. So urogenital trauma, this is a male, right?
This is male, yeah.
Yeah, so urogenital trauma, is that an issue? How do you work that up? Do you just stick a Foley in, or do you do some IVPs,
That's a good point. You have to be aware of that. When you put a Foley in, you have to watch for bleeding in the urine. You have to check the CT very carefully. So that's the way to do it.
I think pelvic plating is very good. Do you have a view of the pelvic plate, of the anterior symphyseal plate? Do you put that on the top or the front? Do you do
on top of the symphysis.
Professor von Glinsky, Alex, any thoughts on this? I mean, this looks beautiful. This looks amazing. Neurologic injuries, urologic injuries, polytrauma setting, staging, interdisciplinary collaboration. Share your thoughts with us.
I mean, it's obviously a tough case. It's polytrauma, so it's in the right hand in the Bergman style. I love the iliac screws, obviously. I would argue that they look like traditional iliac screws. They would put right through the PSIS. If there's a young patient, I suppose it works, but if you talk about geriatric trauma, there might be a way to put them from the inner part of the iliac crest to avoid hardware issues, because in most of those patients, they do well, but they got trouble with a soft tissue covering, but that should be fine. And I love the way they use the cross connector to probably replace the fracture. Did you do any decompression on the S1 root, or was there any neurological deficits prior to surgery? Because it looks like the fracture was going right through the S1 foramen.
Yeah, if there was any neurological injury.
Was there neurologic injury?
No, it was neurologically intact.
Baz, you're one of those young guns, Professor Ishak, who uses high tech and everything. This hardware looks absolutely perfectly placed. What's the role of enabling technologies to try to make this kind of fixation as accurate as possible in a highly unstable lumbopelvic situation?
Yeah, I mean, we are like a huge navigation center, and because you always like to go for 140, 160 pelvic screws, but I don't think we could have made it better than Professor Yilmaz. I mean, even with enabling technology, I think experience is the main goal here.
Right, it looks beautiful.
What are your thoughts on like using polyaxial ilium screws? Because like in those situations, we still use the old system with monoaxial screws, and sometimes a little bit tricky to get everything in place. But in those cases, you have the huge advantage that you can basically use that as a joystick in order to do the proper reposition. What are your guys' thoughts on that?
Polyaxial screws, monoaxial screws for lumopelvic fixation. Alex, maybe I'll punt that to you.
I mean, obviously the reposition maneuver is a bit tougher if you use polyaxial screws. But I think it's easier if you have monoaxial screws, but it can be painful to adapt the rods to the monoaxial screws. So I think polyaxial is much easier, but I guess Professor Schildhauer would, so our old chairman, he would recommend using non-polyaxial screws for the reposition maneuver because it's better to reposition.
Do we actually have biomechanic testing on that or not?
No.
No. But you used crosslinks, which I think is a really big deal down towards the pelvic. So you connected the left to the right pelvic crest. And I think the crosslinks that you used are 1 or 2. Did you put 2 crosslinks in?
In this case, I think we did 1. Sometimes we use 2, depending on if you go to L4 or L5.
That's another one.
The instability. But in any way, you have either to do cross connectors or do SI screws additional.
Well, it's a great case. So let's move forward with your other parts.
So in this, like for this case, my key point would be high-grade instability needs a high grade of stabilization, which means you have to fix it with a lumbopelvic fixation. Case number 2, 80-year-old male, ski accidents, no comorbidities, pretty active, pretty healthy. So, and this is how his CT scan looks like. So he has like a unilateral posterior anterior pelvic fracture. And as you may have noticed, his SI joints are almost fused. And also there's like some comminution in the fracture area.
So this is a phenomenon. We have more and more patients in their advanced 80s and older who are very active. You can't call them elderly except for numbers, and they still do stuff, but a lot of other things happen: atherosclerosis, bone stock, arthritis, distorting the joint anatomy. So is this patient neurologically intact?
He's intact.
Other organ systems are reasonably healthy? Out of control diabetes,
Monotrauma.
blood pressure?
Everything okay.
I'll call my colleague, Dr. Amir Abdul-Jabbar. He's in our other hospital in the beautiful Issaquah. It's a beautiful sunny day here in Seattle. For our visitors around the world, we have a wonderful attendance today on this special day. Amir, what would you do? So older guy, this could be a patient right outside of your hospital, which is right in front of the mountains. What would you do? If Amir can't go live, I know he's online, I'll ask Professor Ishak, what would you do? So fix him, get him up with a binder, say, you're tough, let's go?
I mean, we're always kind of aggressive, but like back in the days, 8 years ago, we said, okay, let's do and treat and fix over 80s, and nowadays it became over 90s. Like for us, there's no option than stabilizing the patient surgically. I mean, the anesthesiology is as good as it has ever been here, like in the world, I guess. So for us, we would go for surgery, of course.
So there's, for those visitors from around the world here today, there's an intense rivalry between German centers. Professor von Glinsky, fire some SI screws in there, pelvic screws, give him a lumbar binder, see how he does.
I'll go for an SI screw. Be a bit worried about the bone stock in the ala because it looks a bit mushy, but maybe a SI screw and to put a plate on the symphysis, which was broken as well, I guess. She had an upper pelvic fracture, so plate up there and SI screw, maybe with some cement to make it more suitable. Even maybe 2 SI screws, one S1 and one S2 screw to avoid rotational instability. I wouldn't go for pelvic fixation in terms of lumbar pelvic fixation. Talking about soft tissue problems, probably SI screw percutaneous to avoid too much trauma. Mobilize over the other side, so tell her 3 months, no weight bearing on the side where I put in the SI screws.
So we need to move forward, but we have large congruence, I think, in general with SI screw fixation.
All right, so this
Drum roll and old but active. That's me.
And we actually did a lumbar pelvic fixation because the fracture side is comminuted, and he had a dislocated anterior fracture as well. So you could, of course, you could go to do like an SI screw only, probably in addition with an S2 screw, but then you have to fix the anterior pelvic rami as well.
So unilateral lumbar pelvic fixation plus SI screw. So you gave it a very stable fixation. And I want to point out the other SI joint looked fused, right? So the left side was actually spontaneously fused. So interesting little sub-variable.
So that would be my second key point. Age is an important factor, but still it's just a number. So for us, like what I think in terms of decision making, the biological age is much more important. Case number 3, 91 years old, female, ground level 4, a huge mishmash of comorbidities. And so we did a CT scan, and this is how it looked like.
Again, what was the velocity of injury? High kinetic, low kinetic injury?
Low kinetic injury, high ground level fall, and as you can see here, she has like some
severe
anatomic
atherosclerosis, and there's something weird. Can you go through coronals again? Can you slip over? So by the way, for those who don't know that in our country, so in the US of A, ground level falls are now the second leading cause of death.
Yeah.
So GLFs. And I actually was just called, I'm on call right now from an outside hospital. They wanted to send us a patient with a T4 burst fracture from a ground level fall.
Yeah.
So there's some lumbopelvic anomaly. How often does that happen?
It's up to, according to the literature, it depends on the study you're looking at, but up to 20% or even more. So, and that's why I pulled it up again, like the 6 signs and factors, like in dysmorphic sacrum, you have either a mammillary process, you have a tongue in groove sign at the sacroiliac joint, you have a still existing disc at the sagittal plane, you have an acute sacral slope, and you have a pelvic which is basically not recessed in the pelvic ring, and you have like irregular looking neuroforamina. So this was a case.
Just as a quick reminder, Professor Ishak and I had made discussions about this. In our spine world, we say about 10 to 15% of patients have a lumbosacral transition anomaly like Bertolotti syndrome, unilateral, bilateral, right, Baz? What do you tell your residents?
Well, actually, I would say a minimum of 10%. Sometimes or very often it's overseen because I'm not sure if the residents in neurosurgery or orthopedic surgery are familiar with Bertolotti. I mean, those patients we see, they had like years of conservative treatment, got injection, and in the end, nobody could find the problem, what they have. And I think Bertolotti is a real issue and causes a lot of pain.
Very true. It's overlooked in the MRI era. So CTs and plain films still have a role.
Absolutely. So this was a patient, like a really tricky case. So we discussed this with the family, and we tried to mobilize her with an adequate pain medication, but it didn't work out pretty well. So we decided to take her to the OR to fix it with an SI screw. And in the sagittal plane, using the fluoroscopy, we weren't unable to find a safe trajectory, neither for S1 nor for S2. So then we did basically a stability testing in the OR, and it turned out like stable, so we didn't fix her. So we went on with the conservative treatment, and but I don't think that those cases can be fixed with an SI screw or with an iliosacral screw or an S2 screw. So in case those patients are unable to mobilize, you have to discuss if you go for a lumbopelvic fixation, but you have to be really careful with those 91-year-olds. Yeah. So key point for me, dysmorphic sacrums are always a challenge. Do no harm. Sometimes no operation might be the best treatment. Case number 4, ground level fall again. A little bit of dementia. So this might be like a problem in terms of compliance. And this is the fracture she had. So she had a fracture side at the anterior pelvic. And then as you see, like without any dislocation, a posterior pelvic ring fracture. So now you have the situation that you have a lunar. So actually we weren't sure if this is like a unilateral or bilateral pelvic fracture, but still, anyway, you have like an incompliant, probably incompliant patient. So what do? Do you like fix her right away? Do you like try conservative treatment first, do some PT, some pain medics, and see where it goes from there?
I mean, the oldest stability test for me that I like is to mobilize a patient. You can give them a lumbosacral corset, and it tells me a lot. So in a neurologically intact patient with a single system injury, low velocity injury, trying to mobilize them I don't think is a bad idea. In an osteoporotic patient, the other question that I have for you is, our physiatry doctors like to put in cement, so they do these sacroplasties. I don't know what your thoughts are on that, but I would mobilize the patient with a lumbar binder and see how they do.
I mean, we are very restrictive when it comes to sacroplasties. We actually don't do it because we think it's like kind of biomechanically comparable with the situation you get when you do a kypho on a patient. So basically you're fixing one side, but at the same time you're creating a problem for the next level right next to it. So that's why we don't do it.
All right, so what do you do?
So we mobilized her, it didn't work out, and then we went to do like a percutaneous screw fixation at the front and one side, and at the back, like bilaterally with iliosacral screw.
Dr. Ishak, Professor Ishak, are you proud of those screws?
Yeah, absolutely. I mean, they did a phenomenal job. And I always have the problem if the patient's incompliant, I still try to bring him into the OR, because if you tell him, okay, you have to wear your lumbosacral corset, here's the pain medication, come to another appointment for a checkup. I mean, if they're incompliant, they will not come and they will not follow your recommendations. So I think surgery is the way to go.
Do you ever get, Emra, these iliosacral screws? I never see them get halos, or do they ever loosen up?
They do.
Do they really?
They
I've
do
never seen
sometimes,
that
but
before.
it's actually pretty rare. But like when you have patients with like severe severe osteoporosis, you can get a halo sign. So
What do you
have
do in
that.
that case? Do you go and take it out, or you just leave it if the
Take
fracture
out,
heals?
take another trajectory, probably try S2. So it depends on the situation.
Yeah.
Yeah. But that's a good point. Yeah. So key point for me in this case would be failed mobilization in non-displaced unilateral fractures. You have to go for a percutaneous screw fixation. So case number 5, 69-year-old female, again, ground level 4, no major comorbidities. And this was her CT scan. So as you can see, there's a fracture on the left side, posteriorly. And you note something in the sacral ala right away when you look at the CT scan. So there you see the fracture again. We didn't see a fracture on the other side.
Is there a role for physical exam still? Do you roll the patients over? Do you move the pelvic wings? Do you do a compression test? Anything like
exactly. And you do that, and you have to ask a patient and see if they have like a pain on the posterior pelvic, and then you have to go from there. But when you look at the CT scan, this is not a normal looking CT. That actually is her CT scan on the left side. So this is not the way a normal sacroiliac should look like. So there's some severe osteoporosis. It looks much more like a Swiss cheese, in my opinion, than a normal sacroiliac. So difficult.
Yeah, we call that a fatty ala, or basically a vacuum ala. Hounsfield units, so does that play a role here in the pelvis? It's been kind of validated for the spine, and we use that 100 to 110 moniker as a density test. Is that validated for the pelvis? Has anybody looked at that?
Not really. I mean, there are like some studies out there regarding osteoporosis in the sacroiliac. But we use it but it's more like a modifier in the decision-making process. Yeah. All right.
Does the bone heal as well if it's that vacuum?
Good question. So that's always like a little bit like a bet, basically, if it's healed or not. So there are like, at least that I know of, no risk factor stratification that gives you basically insights of this, if this is going to heal in 6 months or 1 year. So, yeah. So how would you proceed? Mobilized again?
Mobilized.
Didn't work out. So, and then we said, okay, we go for surgery. We have to fix her.
Magic screws?
Magic screws, magic iliosacral screw. And then something happened that happens more often in recent years. You fix one side, you didn't see anything on the other side in the initial CT scan, and then you see in the post-op CT scan that the other sacral side is fractured as well. So we mobilized her. She had pain on the other side as well, so we have to take her back to the OR and fix the other side as well. So that is something that happens more often in the recent years. So, and my question for the audience is, what do you guys think about an MRI scan initially in those patients?
So MRI is a workup. Let's start with Baz. You're in a neurosurgical hospital at the Universitäts Clinic Heidelberg. You get an MRI on everybody, right? You don't enter your ER without getting an MRI.
Almost, yes. I mean, we have like 3 MRIs a day and night available all the time, so it's a kind of luxury situation. Yeah, so sometimes what we often see with the spine, even if like in a CT scan, you're not sure, is this an unstable fracture or not, we always would like to see the surrounding tissue. And if we see some edema, then we know, okay, there might be a high likelihood that it is unstable. So then we can say, okay, we proceed with the surgical treatment.
So MRI is more sensitive, CT is probably clinically more meaningful. Is that a fair summary, Alex?
Yeah, I guess we would go for a stir sequence in all the patients, just stir sequence MRI. It's shorter, so it's 20 minutes. So if there's a pelvic fracture and like any lumbosacral fracture, they get a CT scan and an MRI scan, but only a stir sequence because it's faster. We only have 2 MRIs, so we have to be more. We don't have the luxury of 3, so we use stir sequences.
So, and then desperately osteoporotic patients, should we just preemptively put in bilateral screws? I know in our country this is not uncommonly done. And then the other question is in these osteoporotic patients, bigger screws. So these are, I don't know what caliber those are. We usually use 8.5 or larger screws. I think there's some manufacturers with 10.5 millimeter screws. Does that screw diameter matter? Alex, maybe I'll stay with you there.
I guess it would matter. But if you see the alien on one side, there is no bone stock. So if even put in a bigger screw, I think it won't hold up. So I would prefer 2 screws on one side to avoid the rotational instability. And I know there are some screws where you can apply cement over the screw. So if there's no bone stock at all, I would probably add some cement to make sure they don't pop out.
Any concluding things?
No, absolutely, I totally agree. We use the system with 7.2 millimeter screws. We don't have any other sizes, but like, yeah, absolutely, it would be a reasonable thought to put bigger screws in those cases. So the key point for me in this case was like, don't miss any injuries, especially when the patient's still complaining in a postoperative course about pain on the other side. And you have high rates of missed and undiagnosed injuries in elderly patients. This is true for osteoporotic vertebral fractures. Like some studies report even like up to 60% missed injuries in those patients. So you've got to be aware of that. So that brings me to my last case, 88 years old, female, ground level fall, again, like a mishmash of comorbidities. And we did a CT scan again. And she represents like one of, in my opinion, like major problems and major questions in elderly patients. She has, as you can see, a bilateral fracture, and I'm giving you the sagittal CT scan as well.
Wow.
So there you can see there's a transverse component as well. So she might be, like according to the AO classification, I will come back to that later, C0 or C3. But don't forget the Roy-Camille classification, even though those are only for pure transverse fracture, but still it's very important. So what would you do? So actually it's spinopelvic dissociation, so this should have been fixed, stabilized.
I mean, again, I don't like this very steep sacral inclination angle. The patient's obviously very elderly. She sounds very sick. Her comorbidity index, her Elixhauser score would be terrible. If she's neurologically intact, I try to mobilize her with a lumbar binder. I stay with my guns. If not, again, don't know what to say. Probably, I would try to avoid an open surgery. I'd try to probably put pelvic screws in before she falls apart. So within the first 2 weeks. Thoughts? Rod?
Yeah, I mean, I think, those are difficult cases because usually you can't correct the deformity. You can do a decompression and just stabilize it.
Yeah.
So
Let me ask a tangential question to Baz. Is there something like a bilateral alar fracture, or are they always combined with a transverse fracture?
I always think they are somehow combined, although I don't always see those. Like when I'm thinking, okay, there must be a transverse fracture and I can't see it, but I still believe there must be an additional fracture beside the both alar fractures.
Yeah, I agree. Just the other day, I had a colleague from Indiana try to talk me into that this was a true bilateral alar fracture, and we had a lengthy discussion over the phone. I just said, I can't believe it, but I thought your answer is great. I should have given that. You're politically way more astute than I am. I was categorically, yes, there's a transverse fracture. I can't always see it though. Yeah. Okay, let's conclude.
100% agree. So, and I agree with you, Jens. So you're trying to avoid an open surgery. So that's why we did a percutaneous iliosacral screw fixation bilaterally. But those patients are like really difficult to treat. So the best treatment option for geriatric C-type sacral fractures has yet to be determined. And I want to conclude my talk with some thoughts on the AO, spine sacral fracture classification. So what I don't understand, and maybe the audience can help me with that, I thought this course is about like basically categorizing the severity and from A to B to C and from C0 to C3. But like if so, and if you combine that with the old Dennis classification, you should basically switch B1 and B2 because we know from the studies back in the days that fractures involving the spinal canal have a higher rate of neurological deficits. So it's like the more severe injury, in my opinion. And as well as you already have seen, like in the former case, in my opinion, there's not something like a C0. So actually, in my opinion, you should put that together to C3.
I'll ask one of the residents. She's actually here from Bochum as a visitor, Dr. Eileen Speakerman. Dr. Speakerman, are you taught the AO system?
I know.
No?
I don't use it.
You don't use it? We have Dr. Gerstmeier here. Are you being taught that system?
Well, generally, yes, but I think for the pelvic or posterior pelvic fractures, sacral fractures especially, we rarely use it.
Aha. Of all the AO systems, this is the poorest correlation and poorest disseminated. I think there's a reason for that. You pointed out things very well. Shall we conclude this part one?
Let's conclude. Hopefully, I was able to show you different fracture patterns and to basically make clear that those two CT scans are not the same fractures, even though they look very similar. They are not. You have to make like a tailor-made, a custom-made approach. And for me, in my opinion, it is very important. Like fracture classifications are great, but you have to go for the big picture all the time. Then you get a beautiful view and a better outcome for the patients. Summarizing the problems in lumbopelvic trauma, the world is aging. You have more elderly patients with a less favorable outcome. We have little experience and a lot of like theoretically like a lot of options. And the lumbopelvic section is still the intersected area, so you have to familiarize yourself with that area of to manage, like to get pelvic and a spine surgeon together. And the key points are classifications are great, but the big picture is more important. Thank you very much. Any
Awesome.
questions?
Thank you. Now for a repartee from Heidelberg, Professor Bazem Ishak is right there, and he has a couple of thoughts in response to this excellent presentation. Thank you very much, Emre. Baz, do you want to take control of the slide deck?
You're still muted, Dr. Ishak.
There, we are seeing your slides.
So, can you hear me?
Yes. If you go into present mode, bottom right in your screen, yes, there you go. Perfect.
Okay, here we go. So thank you very much, and thank you, Dr. Yilmaz, for this amazing presentation. I think lumbopelvic fixation is a very important topic. I mean, we see a rise in the elderly patients, and these fractures are very common nowadays. So what options do we have? And I would like to start very quick, and because we know we have so many residents all around the world watching this, so we were talking about this and that screw, but how is it technically done, right? So what options do we have? We have the iliac screw, the classic one. This is what like Dr. Glinsky and Dr. Imre always taught us in the last slides. We have the S2AI screw between the S1, S2 neuroforamen, 10 millimeter lateral to that. And we have the modified iliac screw where we don't aim through the PSIS directly. We go medial to that, but are away from the iliosacral joint. So, but which screw or which way is the right way or the right one, the right technique, right? Is there any difference in terms of biomechanical stability, in terms of stability itself? We in our last years at SSF, and we did some anatomical analysis, and we've seen like the pelvis has like a weak spot we didn't know before actually, and like the classic iliac screw is the screw where we just aim from the PSIS to the ASIS. We also could aim from the PSIS to the AIIS, right? And this is how it looks like in a model. And we all know we need connectors. And we always thought this is a weak spot, but I will dive a little bit deeper into it later on. The problem, and this is what we've seen and what was mentioned a couple of minutes before, is that we have to countersink the screw. So we have to remove some bone from here and insert the screw directly into the bone to prevent pressure ulcers. I mean, in very thin patients or in kids, if we do pediatric deformity surgery, we always see there's like almost no layers between the skin and the screw head. So we have to take this into account and be prepared for connectors. I mean, here in this model, it looks very easy, but we all know the real world can be difficult and it can be very challenging, especially if you use monoaxial screws. We don't have monoaxial screws, we use polyaxial screws, but still it could be a struggle. And if we look for the modified iliac screw, and this is what Dr. von Glinsky mentioned a couple of minutes before, but maybe you don't know what this means. This actually just means don't go through the PSIS directly, go medial to that, right? Medial to the PSIS. This is the sacrum, this is cranial, this is caudal. Go medial to that, stay away from the iliosacral joint, because the theory is to stabilize the iliosacral joint, not to fuse it with like other techniques. And you see like the prominence of the screw head is not as much as like the classic traditional iliosacral screw. So, and this is the main goal and the best benefit is you don't need to bend the rod, because we know if we bend, there might be some weak spot generated by the surgeon himself if we do too much bending with the rods, and you don't need connectors. And this is how it looks like. This is the modified iliac screw. I mean, we have to stay away from the iliosacral joint, which is here. Here it's very close, but it's okay. I've looked it. Otherwise, I would not have put it into my slide. And yeah, and you see it's medial to that, the entry point medial to the PSIS, and you don't need a connector. Easy going. You have just put in the lordotic rod and fix it, and you're good. So, and what is the S2AI screw? And this is like what Dr. Yilmaz is actually renowned in Europe for this technique, is just go between the S1 and S2 foramen, 10 millimeter, we say, just lateral to that, and aim a bit caudally and laterally about 30 degrees, and then you're very good to go, right? And your starting point, and this is what you can always take into account, could be or should be in line with the S1 pedicle anchor. And what we also could do with this technique is to put a dual screw fixation, dual sacropelvic fixation is possible. But be aware, you have to, the sacrum is very weak, it's always osteoporotic, so it may break. And what you always have to take into account, you have to go through the iliosacral joint. And this is like a really hard joint, you have to pass it, right? This is very, very important. Otherwise, you will land in the abdomen or the pelvis itself. And the ideal trajectory is above the sciatic notch. This is very important. We will see it in the next slides. And here's another image. I mean, you can also go like aim for bicortical screw with the acetabulum, but stay away from the hip joint. Like this is important in revision cases, but yeah, very rare. And here you see you have to pass the iliosacral joint, and this is important. If you do not pass it, you might end up here in the bowels or something. So you have to be sure you're past the iliosacral joint. So how about the biomechanics? I mean, on one hand, okay, we have the traditional iliac screws available for 30 years, so it's a nice screw and it's well known for deformity surgery and revision surgery. We have the modified iliac screw where we don't have the PSIS and it's not that prominent and we don't need any rod, and the modern nowadays S2AI screw, which can also be done with 100 or 110 millimeters. So which screw in terms of biomechanics is the best or the most advantaged? And for that, Professor von Glinsky from Essen did a biomechanical testing with 18 sacropelvic spines, which were divided into 3 groups. We have the traditional iliac screw, which is here. This is the S1. We have the S2AI, where it's always in line with the S1 screw, and the modified iliac screw, which is medial to the PSIS, but also in line with the notch of S1. And what we found and what the authors found was that there was no statistically significant difference between all three fixation techniques with regard to construct toggle and rod strain. And this is what we didn't know before, because what we also found, or the authors found, was that offset connectors are no weak spots. And we always were thinking, okay, maybe these are weak spots, therefore we should go for a modified or S2AI technique. But in fact, it was not a weak spot for lumbopelvic fixation. And what we finally conclude is that no clear biomechanical advantage of any pelvic fixation technique. So it depends on the surgeon's experience and surgeon's preference. So, and a very important paper which was published by Professor Yilmaz was, what are the best trajectories for multiple iliac screws? I mean, we know dual pelvic fixation, triple pelvic fixation, and in rare cases, quadruple pelvic fixation, right? But this is something special. So, and what Professor Yilmaz did at SSF was like looking for a anatomical and radiographical and morphometric cadaveric analysis. And for this, 4 human pelvises were prepared. We looked at the anatomical considerations, the morphometric analysis. We looked for the bony canal length, for the intercortical width, and the longest distance to the next area. We have here with trajectory 1, PSIS to the AIIS, and trajectory 2 is between PSIS and AIIS, and 4 is like the PIIS to AIIS. Be aware, here's the sciatic notch. You don't want to deal with that, right? And what you also can do is like the iliac tubercle to the AIIS, but be aware we have like a weak spot here, but it's possible. You just have to take this into account. And what you also can do as really rescue possibility is like a perpendicular line from the lowest spot perpendicular to the traditional iliac screw. I mean, these are like 4 or 5 very good options. And what we found out, we analyzed the screw length, the bony canal, we looked CT scans, and we analyzed and looked for possible structures we won't deal with, like bowels, arteries, etc. And what we found out is that like the red line, the trajectory 1 is the best option. If you want to combine a dual pelvic fixation, just beneath to that, you can take trajectory 2, which is between PSIS and PIIS to AIIS. T4 is like PIIS to AIIS, which is actually a strong and very good screw, but you have to take the sciatic notch into account. Just stay away from it and you're good to go. So these 3 spots are very nice. And then the third one here in black is also a very nice trajectory. But we know there's an anatomical weak spot just right above. So be careful with that screw. Otherwise, you have at least 2 or 3 good options for dual and triple pelvic fixation. So thank you very much. Just in a brief overview.
Thank you. Great. As we're getting ready for section 2, and for our audience, we may not be able to go for the osteomyelitis section in great detail because Dr. Plumer is stuck in the OR, so we had a little bit extra time for lumbopelvic fixation. Alex, do you remain with your insight that trajectory 1 is the best?
Yes, so if I may say some words, so actually I'm still not a friend of S2I screws in general, because I don't like putting in screws to the SI joint, which might be intact. And if we take Emery Dilmer's talk in regard, where we talked about sacral fractures, so most sacral fractures won't allow any S2I screws. So I believe that the iliac screw is it's not the better screw, that's right, but I prefer iliac screws whenever possible. And if you use this modified technique, you can avoid violation of the S2I joint. You got good, strong bone, and you got to take care or keep in mind that you can put in longer ilium screws compared to SI screws. So you can go for 130 or 140 millimeters iliac screws, and I guess you can go for 100 millimeter S2I screws, depending on the individual anatomy. Furthermore, all the biomechanical testings that have been done they compared 90 millimeter S2I screws versus 90 millimeter iliac screws. So I still think, even if you couldn't prove it, that the iliac screw, good iliac screw might be a bit better in terms of fixation strengths compared to S2I screw. But that's just a personal view. I can't prove it yet.
So we saw two techniques. We have your former colleague, Emre Ilmaz, has beautifully done traditional radiology and experience guided screws. And then we have young Wiz with Baz Ishak, who has a lot of guidance systems. How do you put yours in? Guidance systems?
No, I just use like fluoroscopy. Go for a lateral view. In the lateral view, you put in the screw. You make sure you got a good lateral view. You see the Asiatic notch, and then you switch to inlet, outlet, obturator inlet, obturator outlet views. You get a good view of the teardrop, and then you don't need any robotics to put in an SI screw, S2S screw, sorry, or iliac screw, doesn't matter. So we don't use robotics for those screws.
Great presentations all around. Thank you. Yeah. And even Dave Pauly, who's very well known in the US, acknowledges your work, you guys' work, so really well done. Distal junctional failure. The sacrum is kind of a distal junctional failure, but to take us into this topic in greater detail, Cliff, Pierre.
Yes, again, good morning, everyone, and again, welcome colleagues from Germany. I'm going to present the case really quickly so that we can get to our next speaker, where we can go into further detail on our current research project that we have on this topic. And so, have a 54-year-old male with intractable low back pain that radiated to his bilateral low extremities. This pain had been ongoing for the last 3 months. Failed conservative management, for which he was then seen in our clinic. Significant past medical history is alcoholic cirrhosis, as well as diabetes and hypertension. Had presented with thrombocytopenia. Of note, he is an obese patient with a BMI of 40. Intact neurological exam as well as sensory exam, and these are his past treatments conservatively that failed. Flexion extension x-rays here just shows a mild L4-5 anterior listhesis. Of note, you can see an L1 lucency in the vertebral body at L1, which prompted this image, an MRI of his lumbar spine, with and without contrast. Here we see a large enhancing lytic lesion of the L1 vertebral body that extends to the posterior elements with significant variation towards the left side and extension to the neuroforamen from T12 extending down to L1, L2. There is also severe spinal canal stenosis due to the expansion into the spinal canal from this lesion, which is concerning for possible malignancy in this patient. CT also, again, shows a well-defined lytic lesion. Here we see destruction of the vertebral body and the cortical bone. Again, extension into the neuroforamen, specifically on the left side at T12, L1, L1, L2. And we see destruction of the end plates inferiorly and superiorly at L1, all on the left side, extending into that left pedicle and transverse process. So talking about scores, I'm not sure what scores you guys use primarily in Germany. Here we have a SIN score of 10 for this lytic lesion. We can also talk about the NOM score as well. And again, in summary, this is what we have in terms of the presentation, an L1 pathological fracture. We did do a pan scan. There was only some indeterminate lesions noted in his liver, which also increased our suspicions due to his history that this also could be malignancy. MRI of the neuroaxis was negative. One thing here we predominantly use at our institution is also Hounsfield units. So measuring the Hounsfield units on the CT scan, we noted he was concerned for osteoporotic bone. So these were some of the treatment options discussed. With concern for malignancy, we knew that we needed to get a biopsy, and with the concern of severe canal compression, surgery was going to be in his future. Now, the approach is, you do it posteriorly or laterally, addressing the L1 vertebral body. Again, with the posterior approach, doing decompression and biopsy at the time and debulking as much as you can. How many levels you would proceed with this procedure, and then with the concern for osteoporotic bone, would you augment the surgical plan?
So I'll go to Professor Ishak if you go back to the neuroimaging. Baz, yeah, the MRI. Neurologically, quote, intact, but the guy can't get up. He has one of those indeterminate SIN scores. High-grade epidural compression. He simply can't mobilize. Reasonable person, large man, alcohol history. Probably hepatoma, but we don't have biopsy. Do you wait for a biopsy, which in our place nowadays with all the genetic differentiation takes a week or more to get back? Or do you just go for an excisional biopsy and fix the lesion? If so, what's your approach?
Yeah, it's a very good question. Actually, I always like to wait for the biopsy because you never know what's going on. It could be a sarcoma where it could be like fatal if you do too much. On the other hand, he's like, as you really said, I mean, there's no difference to Germany. I mean, we still wait for 1 week at least to get like the details we need, and the patient has pain. I mean, his neuro is intact, which is okay. But I personally think I would go for the least invasive thing. So I would bring him to the OR, would do a decompression of the spinal canal, although I don't know what entity it is. And I know it probably would be wrong, but I would go for a decompression only of the spinal canal, wait for the biopsy and to see how to stabilize posterior only or a combined procedure.
Alex is frowning. Alex, what would you do? One facet joint is gone. Again, he's on the higher side of the SIN score. The
I would
NOM
go
score
for
was
posterior first, maybe 2 or 3 levels above, depending on how good the screws feel. Then take away or go down the pedicle on the left side, which is obviously tumor, do a tumor debulking from posterior as much as can get, full laminectomy. And then after first stabilization and decompression of the cord, maybe second time go in and do a corpectomy, put an Ulrich cage or something like this, expand the cage from the front, get out the whole tumor. But it would be good to know the posterior part would be not too much concerning, but if you take out the whole tumor from the front, because I think you need to do it because there's no backing up from the spine because the ventral part is gone. But I would love to know what tumor it is and think about embolization before I do get too much work done and have a bleeding tumor.
so biopsy, embolization, all really good points. And learning points, as we'll see.
So yes, great points, Dr. von Glinsky and Dr. Ishak. So we proceeded again with the stage 1 posterior approach. These are the intraoperative films. Again, doing a short segment instrumentation with cement augmentation. This was noted to be a hypervascular tumor. Frozen pathology was consistent with differentiated cancer, likely hepatic in origin. And these are the immediate postoperative films after that first stage, as you noted, just getting some tissue, trying to define how aggressive this lesion is in terms of the tumor spectrum, and then proceed with the stabilization anteriorly. And so we then brought him back.
And I want to acknowledge I had significant cement leakage. I take responsibility for this. And Dr. von Glinsky already said 2 above, 2 below, and this section is titled Distal Junctional Failures.
Correct.
So cement leakage, I got away with something very lucky. I think we did embolization, did we? Yeah. I think
Yes,
he
we
had an
did do
embolization before
embolization.
because it was a hypervascular lesion.
Yep.
And it was a hepatoma, hepatocellular cancer.
And
so this is our
here we are
embolization, yeah.
embolizing one of the left L1 radicular arteries that's a feeder to the tumor prior to approaching it laterally. Here we did a far lateral approach for L1 corpectomy. These are the intraoperative films, placed the corpectomy cage in that space, and then these are the immediate postoperative films. Patient immediately felt better with related to his pain. And then, again, this is just a prelude to the rest of the hospital course, as you see some of the leakage of the cement there. Again, no intraoperative issues related to that leakage. And so postoperative day 2, patient was aggressively mobilized with the PT, then began to complain of new severe pain in his back. CT imaging was repeated, noting a new L2 burst fracture, significant cage displacements, and the L2 screws were pulled out. In this case, again, consistent with distal junctional failure for this procedure. And again, there's a short article by Dr. Lenke and his group, again, talking about ways to address and strategies to avoid distal junctional pathology, especially in those that are having thoracolumbar instrumentation. Again, for us, when we plan our revision surgery, doing our best to improve mechanical support and extension of the hardware distally, as well as maintaining proper alignment. And so this is what we did. We proceeded to go back and posteriorly, and as Dr. von Glinsky mentioned, extend our hardware distally another 2 levels. And then we did a second stage to address the cage and appropriately place it while taking some more bone from that L2. Patient did well. postoperatively. Was able to proceed with further treatment for his cancer, had undergone radiotherapy and immunotherapy, and then these are his 6 months films. Again, standing, lateral, and AP images, and with his spinal pelvic parameters as well. And again, I would like to talk about the technical considerations of distal junctional pathology, but I would like to invite our research intern.
So our research intern is Dr. Ziad Daher, and one of our great features here is that we're so proud of. We have young research volunteers who can help us with studies. Quickly before as he's getting ready, Baz, should have just gone more distal right off the bat. 2 above, 2 below is one of those old things for tumor and infection cases. We obviously are always smart afterwards. What did I do wrong in my decision making here?
Actually, nothing, because we nowadays, what we do now, we came like from 2 above, 2 below, like Professor von Glinski from Essen. But nowadays we do just 1 above, 1 below, and do cement augmentation to keep it short. So I think this was a good decision.
Alex, did we do technical failures? Was the anterior cage not large enough? It was a nice, large far lateral procedure, but there was a little gap on that initial one. I know you're very kind and defensive to me, but...
I mean, it looked beautiful. I'm sure the footprint was as large as possible. What we sometimes do in case we've been worrying about the bone quality, we use those little cement injections and we put them from the lateral view, put in some bone fillers, like right below the end plates, and do like a kyphoplasty from the lateral side. So we put cement right below and above, like below the ground plate of the vertebra and above the end plates. So we try to avoid the cage to drop into the vertebra. So just put from the lateral side, put in some bone right underneath the end plates. That might have helped, but...
And Dr. Ali Shahid is in the chat room. Thank you. Very astute observation. Did you take into account the L4-5 subluxation? You're quite right. This is one of the reasons why I did not want to go all the way down there. But now we're there. So at some point in time, I'm pretty sure we'll have to deal with his stenosis. He clinically is actually doing amazingly well. He's very grateful. And he clearly was one of those patients who wanted a little bit more stability rather than my attempt at being less invasive, which failed. But you're quite right. The more distal we go, the more we have to deal with degenerative problems. And in the oncologic fight, we did not go there yet, but that's a battle to be fought at another date. So we can't win everything right away. Distal junctional failure, Ziad, great job here. You're looking very good. He's heading out to Wake Forest Medical School next, and you're wearing, I think the school colors are
that is correct.
Represented in your tie. Nice, gold and black.
Okay, yeah, so thank you for the introduction, Dr. Chapman. My name is Ziad Daher. Just a couple quick facts about me. This is my first time doing this sort of talk. So for those of you that don't know me, I grew up in Redmond, Washington. Family originated from Lebanon, south of Lebanon, and studied at University of Southern California, where I received in 2021 my Bachelor's of Science degree. So in the past few months, I've been working as a research intern for the Seattle Science Foundation, and we've been focusing on this project where we looked at the association of bone mineral density and distal junctional kyphosis or failure, specifically after multi-level spine fusions. And the way we went about it was by conducting a systematic review and a meta-analysis. So as I mentioned, we investigated the correlation between BMD and DJK, but we also wanted to address the gap in knowledge that currently exists in the literature. There are a lot of studies that address PJK and its risk factors and specifically talk about BMD as a risk factor, but there's not much on DJK, so we wanted to investigate that further. So the patients that we focused on for our study were adult patients who underwent corrective spine surgery, and we assessed the measurements for bone mineral density from multiple retrospective cohort studies. And we compared 2 different groups, a group of patients who developed DJK or DJF after their spine fusion, and then control patients who did not develop distal complications. And then we also looked at other relevant outcomes, complications, functional outcomes, and quality of life as well. So for our inclusion criteria, we included patients above the age of 18, studies from 2000 onward, multi-level spine fusions. We actually had to exclude 1 paper that had a single level. And then our minimum follow-up was initially 2 years, but just due to the limited literature that we have access to, we had to reduce that to 1 year. And studies had to provide some sort of qualitative or quantitative assessment of the relationship between BMD and DJK or DJF. So this is a depiction of our Prisma flow chart that highlights how we conducted our literature review. We focused on 5 different databases, gathered articles based on a keyword search, and then screened for any duplicates or studies that were excluded. And that left us with 12 studies that were included in our systematic review and 6 for our meta-analysis. So just before I get to the findings, I just wanted to briefly discuss, there is a lot of variability in terms of the definition for DJK. So distal junctional kyphosis from throughout the literature is typically defined as a Cobb angle of at least 10 degrees greater than preoperative scans when looking in the sagittal plane. And it's typically measured from the lowest instrumented vertebra to 1 level below that. Some papers talk about measuring 2 levels below, but this was the most consistent definition. And then for DJF, it's pretty consistent throughout the literature. It's usually characterized by construct breakage, screw pullout or loosening, or pseudoarthrosis. Now, last slide before the findings, I just wanted to highlight the similarities between PJK and DJK when referencing the risk factors. The shaded gray boxes represent similarities, I guess you could say. For PJK, selection of the upper instrumented vertebra, similarly for the lower instrumented for DJK, preoperative sagittal vertical axis, and then an age of above 60 typically for PJK. It's unknown for DJK. However, bone mineral density is also listed for PJK as a risk factor, so why not explore this a little further for DJK as well? And that was sort of the root of our project. This is an example of distal junctional failure from a systematic review that we found. This is a construct from T5 to the pelvis, and you can see the orange arrows right there point to the screw pullout or loosening right there. Now, for our findings, we generated 2 forest plots that show an association between Hounsfield units and distal junctional kyphosis, and the same thing, that should not be blocked, but that bottom one is for T-scores and distal junctional kyphosis. So for the top one, if that black diamond is straddling the vertical line, there is no statistically significant difference. However, you can see that it's not straddling the line for Hounsfield units, so that turned out to be statistically significant. But for DEXA, it is not. We did not find a significant difference. We also looked into age and BMI as well. We did not find any statistically significant difference for either of these parameters, even though for age, it is listed in the literature as a potential risk factor. However, for SVA, we did find a significant difference, as you can see by the black diamond, and this suggests that failure to correct sagittal imbalance, typically above 5 centimeters, in conjunction with low BMD could potentially be, or put the patient at a greater risk for distal complications. So some of the reasons listed in the literature are cited that could help explain why we didn't get a statistically significant difference for DEXA, is the potential overestimation of bone mineral density. Typically, DEXA scans are done on the hip, forearm, or femoral neck prior as standardized measurements, prior to measuring the spine. The papers that we saw did not report that, at least, so that could be a potential limitation to that. Degeneration, calcification, and sclerosis have also been cited in the literature, typically in the lumbar spine, as potential reasons for this overestimation. And then Dr. Paul Anderson does highlight in one of his papers the potential of using CT Hounsfield units as an alternative to measuring bone mineral density and for managing osteoporosis. And that is the study right there at the bottom. Now, in our study, we did run into some heterogeneity, particularly in reporting metrics. Like I mentioned, there is a lot of variability in terms of the measurement types. Some papers use DEXA, some use CT, quantitative CT. There is a novel cervical vertebral bones quality scoring system that's also referenced. And then that just generated a variability in different units as well. We actually had to exclude one paper from our meta-analysis that measured in absolute measurement of grams per centimeter squared using DEXA rather than a T-score, so we couldn't include that in the same forest plot. And then due to biomechanical differences, we did not want to include the same, or across different spine regions in the same meta-analysis, but we had to, just given the scarcity of literature. For limitations, as I mentioned, heterogeneity of reporting metrics, scarcity of literature, particularly retrospective cohort studies with an outcome comparison. And then a minimum follow-up time had to be decreased a little bit. And then the lack of reporting DEXA measurements or standardized measurements. For future research, some studies point to a preoperative improvement of bone health and quality, specifically through the use of anabolic agents or anti-resorptive medications. We've seen teriparatide and biophosphonates listed as well. Also, more retrospective cohort studies can help elucidate this relationship between DJK and BMD a little bit further, just providing more data to conduct a more robust meta-analysis. And then more and more studies are pointing to lifestyle changes as well. Exercise, diet, no smoking. Smoking has been correlated as well with distal complications. So in conclusion, like I mentioned, there's no agreed upon definition. There's a lot of variability in the data, but preoperative planning has been shown to be effective in some studies. And I just want to leave with one last point, pelvic anchoring. Due to biomechanical differences, a lot of constructs are, especially in the lumbar region, are fixated toward or end at the pelvis. So because of the sturdiness of the pelvis and the stability there, that could be a reason why we typically don't see distal junctional kyphosis reported in the literature as much. And I know it's clinically it could be more relevant in the cervical region, but from what we've seen in the literature, there are some lumbar, but that could be a limitation to why it's not reported as much. But thank you.
Great job. Go back to your summary slide there with the monoclonal antibody. So that first case that we showed with Dr. Davis in the very beginning did have a monoclonal antibody. Go back one more, the nice survey slide. Yeah, that patient was on denosumab. So coincidentally, he was on an anti-resorptive agent for quite a while, like 3 years, and his bone healing was really problematic. So bone healing and denosumab are not compatible if you have a big challenge. Yeah. As you looked at this, the percentage figure, if you just kind of summarize it again for the audience with the slide here, how much or why did it happen that everybody's focusing on proximal junctional failure, not on distal junctional failure? Why do you think that is? Are we just going to the pelvis far more often, or why this focus?
Specifically in recent years, or studies from recent years, we have seen a lot more constructs going to the pelvis. And because there's not that stability at the upper end of the construct, I think that's typically could be a reason why you see PJK and PJF in a clinic or presenting a lot more often. And then there's just a lot less known because of the definitions, how they're a lot more clear for PJK in the literature. That's been studied more and more. But DJK is getting a lot of traction because most of our papers were from 2020 and on. So in recent years, I think we could see in future years a lot more on this topic.
See, I think far more of our patients are getting pelvic anchoring nowadays, and the pelvic anchoring, thanks to the work of colleagues like Dr. Ilmez and Dr. von Glinsky and Dr. Ishak and others, really do better pelvic anchoring now than we've ever done before, and we hardly ever stop in an adult at L5 anymore. Rod, wouldn't you say that that's probably a statistical reason?
I do, but I do agree with Sayad, and I think this is a great review, Sayad, because people focus on PJK so much. I mean, we see these patients all the time in our clinic where, in Emra, we were talking about it earlier, where, there's halos around the iliac screws, the S1 screws are loose. I just think we just ignore it.
Yeah.
So I think this paper is really going to be valuable to the literature because it's actually, I think it's more common than people think.
I would like to point out also, one of the risk factors that was cited a lot was ending the construct above the SSV, the sagittal vertebra, the stable sagittal vertebra. So I think that's a reason why a lot of people are now ending the construct at the pelvis or extending it to the pelvis.
Dr. von Glinsky, I know in your practice now treating more spine deformities, patients with Scheuermann's kyphosis or idiopathic scoliosis. How often are you seeing this entity, and how are you adjusting for it?
Most of the patients we treat with Scheuermann disease.
You're muted. Alex, you're muted.
Better now, hopefully. Can you hear me?
Still can't hear you right now.
Now?
Dr. Ishak cut you off.
I should work now.
And silenced by Baz.
Yeah, I can hear him. Actually.
Okay, you maybe hear me now?
Still can't hear you. Baz, jump into the breach. How often do you see it? Take until we solve the audio problems for Essen.
Yeah, I mean, what we often see
You
is
sound
like,
also, wow, Germany has been cut off.
I think it's the technical.
Just
Better
like
now?
soccer.
Germany has been cut off.
yeah, Germany's cut off.
But
Do you
I
hear
don't know
me?
what's going on right now. Sorry, I will ask Corey and Alexis, who are so kind to run the controls today. So we just have it here as a problem. So John can hear you guys. We can't hear you. So you
Works
can hear
now.
online. So keep talking whilst we sort out our audio problems here in the room. So,
Okay.
so go ahead, Alex.
Okay, well, thank you. So
Lip
obviously,
read.
most of our patients are quite young patients, so in their 20s or like teens. So we are very conscious about fusing to the pelvis because that leads to a lot of restrictions. And we don't have a big problem in terms of distal junction failure or proximal junction failure in young patients because I think they have good bone stock. And especially in the elder patients, it's not only the bone stock, but also the whole topic of sarcopenia, which now comes more and more into focus, like muscle quality and the way they like albumin and stuff. So I think in all the patients, the problem in younger patients after scoliosis surgery, you don't see much of discal junction failure at all, probably because of bone quality. Could anybody hear me up there at Seattle?
We can hear you now.
Question for the both of you. So how do you decide what kind of pelvic anchoring you do? Like, is it an option to do an S1 screw in addition to a sacroiliac screw? Do you do S2AIs, like for deformities? Do you always use pelvic and iliac screws? Like, what is your go-to pelvic anchoring construct?
Yeah, if I talk like for my department in Heidelberg, Germany, we do a combination of S2AI and modified iliac screw. Like it depends on what I like to do. Depends of the S1 anchoring. I always go for S1 sometimes, and this is what we also learned, that if we have a bad angle, we just don't insert the screw into S1. We go from L5 directly to the S2AI or modified iliac screw. So if we need stability, like for L5 issues, we always go for S1 and pelvic anchoring. If it's just like a long construct, L2 to pelvis, T10 to pelvis, we sometimes don't insert screws into L5 or into S1, sorry.
Coming out of your paper now, where are you in terms of consolidating the definition of distal junctional failure? Do we finally have a consensus there?
Yeah, I think for failure, we more so than kyphosis, just because of whether it's one level below or two levels below. But for failure, it really is screw pull-out, loosening, pseudoarthrosis, and construct breakage at the distal end. That's the most consistent. I didn't see anything that varies from that.
Good. Yeah, and I think that's a very important aspect to kind of define these parameters and translate them from the proximal world that everybody's focus is on to the distal focus. Is sarcopenia, is malnutrition something that you've run across in the papers?
Malnutrition, I didn't see as much. Sarcopenia, there might have been one paper, but not enough for me to explore it that much further. So I don't know if I can answer that as detailed.
We're shortchanging our audience on the third part a little bit intentionally. Dr. Plumer, who has done a great job working on vertebral discitis osteomyelitis, was stuck in the OR, so we kind of were able to expand a little bit on our lumbopelvic fixation topic and distal junctional failure, with apologies to the audience. We'll definitely make a special feature for osteomyelitis discitis as well. Really want to thank everybody. Any final concluding thoughts from your end?
I think this was a great session. Thank you very much for presenting this paper. I think it's an underappreciated topic for sure. Coming from trauma, I'm always excited when I see the x-rays like from guys like doing a lot of deformity guys, especially those types of pelvic anchoring, the quadrant constructs, and so on. So I think we heard like some great insights with respect to those topics. So thank you very much, everyone.
Thank you.
I want to thank everybody, and again, today is a very important federal holiday here, which we don't celebrate here in our state. Interesting, it's Juneteenth. June 19th is I want to just point that out to everybody, the day of liberation from slavery in our country. It's a very sore and an important subject. So this is a day of celebration also for us here. But I want to recognize this historical achievement that took place today in the state of Texas, actually, where the day is actually celebrated with a day off. We have to go back to work here today, but this was fantastic to see you, Baz and Alex, and our colleagues from Germany who've done great work in lumbopelvic fixation and beyond. So congratulations to your work and thank you.
Thank you very much for having us.
All right.